Thanks everyone for joining. This is our second community webinar for Pathways. Sorry, I'm multitasking here. And we're really happy to have you all for our presentation today from Selena and from some of my colleagues at Pathways. We've got a fantastic agenda, a packed agenda, and really happy you're here today. So what are we going to be doing? Before we start the agenda, I just would like to ask everyone to please introduce yourselves in the chat. You should all be able to see each other's conversations here. So introduce your name, who you work for, where you live. If you've got anything fun to share about Pathways, please use the chat and use the chat to discuss throughout. We've changed the format of this webinar since the last one so that we hope we can have a little more robust conversation in the chat. So what we'll be doing today during our community webinar, we'll kick off with some introductions of our speakers. The first presentation, our feature presentation today, will be about using Pathways segmentation to tailor and track digital-first healthcare delivery in Lagos State. So Selena we have two presenters from Selena who will be presenting. And then we'll have time for discussion. One of the pieces of feedback we got from our last webinar is we didn't have enough time to ask questions and have really thoughtful discussion from the presentations. So we're building in more time for this session today to allow for you all to interact with the presenters, ask questions about their content, and really get to engage with each other, taking advantage of connecting virtually. Our second presentation will be the Pathways survey. So this presentation will be done by two of my colleagues here at Sonder. And then again, following that, we'll have a time for a really nice discussion where we can recap and ask questions about the survey. I'm sure that many of you will have questions after that presentation, and we're really excited for that. And then to close out today, we'll share a few updates on upcoming events for Pathways. Next slide, please. So who are our speakers today? I'm going to introduce all of our speakers here. I just want to make a note that for the Digital Care First presentation, we have two esteemed speakers from Selena joining us, and Village Reach, who has been a very big part of that project. Susie was due to present from Village Reach, but unfortunately is unable to join due to some family emergencies. So we want to acknowledge the work that Village Reach and particularly Susie has done as part of this project, and wish her and her family well, and certainly miss her speaking today. So let me start off by introducing Leke Jigere. He is a principal at the Selena Center for International Development and Research with over 10 years of experience supporting health system strengthening across African countries. He leads key portfolios, including digital health, access to finance, human resources, private sector engagement, and data-driven delivery. As a project director for the implementation research, he oversees design, execution, and stakeholder engagement. So welcome, Leke. King Ivas Hinshaw is an engagement manager at Selena with over 7 years of experience in strengthening health systems across Africa. He's a project manager for the implementation research, overseeing daily activities and providing strategic guidance to the team to ensure effective planning, execution, and overall success of the project. So welcome, King. Turning over to Lee. So Lee Pine-Mercier is the work stream lead for research and development at Pathways. He has a diverse work experience, including developing new tuberculosis drug regimens, setting targets for the sustainable development goals, supporting community health workers in Nigeria and Tanzania, and setting up HIV care systems. Lee has worked with several organizations, including the University of Washington, Gates Foundation, MEDIC, and FHI 360. And last but certainly not least is Lang Gao. She is a data scientist and mixed methods researcher for Pathways. Prior to joining Pathways, Lang designed and led research and impact evaluation and behavioral experiment projects in multiple countries in sub-Saharan Africa and Asia. At Pathways, Lang drives segmentation, modeling, and analysis efforts while spearheading the revision of household surveys. So I did my best to do justice introducing our speakers, and I think at this point we'll kick it over to our colleagues from Selena to present about their work. So over to you, Leke and King.
All right. Thank you very much. Please confirm you can hear me. All right. Yeah, I'm Leke Jagade from Solina. I'll kick off the conversation here for today, presenting the context and the methodology, and King will take it up from the results through to the end. So to describe the context of this work, next page, please. It's the use of telehealth to reach the underserved population. It is context is based on Lagos. Lagos, in relation to the rest of the country, has fairly okay health outcome indices. If you take the maternal mortality rate, for instance, the country has over 1,000 per 100,000 births. You get below 500 of that in Lagos, which isn't too great, but fairly much better than the rest of the country. And then if you take some pockets of areas in Lagos, you still get over 1,000. So even while the state is doing great on the average, there are still pockets of poor performances here and there. So this work is premised on the need to identify the pockets of underserved, vulnerable population across Lagos. And I think, that brings into perspective why segmentation would be important to us and why we had to adapt the pathway segmentation. To describe the underserved population in the context of Lagos, as we're seeing on the slide here, we identify them as including individuals that have to travel more than 5 kilometer distance to access the nearest health center to them. They are also characterized by poor or low income or financial indices, with earning below the average income earning of the country, below 50,000 naira per month, which is below $30 per month. We have them spending also greater than 20% of their income on health, greater than 80% are classified as poor households within these areas identified, and also classified by having a lot of out-of-pocket spending. In terms of their infrastructure as well, I already mentioned there is not a lot of health facilities, but even the area itself is generally characterized as rural. Lagos State is fairly urban, but the areas we're interested in were the peri-urban or the rural areas of the state. And as you can imagine from all that I've said as well, socioculturally, there's low level of education, distrust with modern technology, among other things. So the use case we're testing is how to expand access to the profile that I just described using telehealth models. Now, there are telehealth models already existing in Lagos that are serving, but typically we find out that they serve, as you can see on the right half of the page, they serve individuals from the high socioeconomic status or strata in the state to medium. So, and interestingly, these are individuals that already use the brick and mortar facilities anyway. So the telehealth wasn't quite getting optimized in expanding access to healthcare. So we're very interested in the adaptations required to enable use of telehealth to meet the bottom row that we have on the right half of the page, which is the low social income strata of the state, where you have underdeveloped urban infrastructure, where you have typically no primary education, a lot of non-professional and low income earners. On the next page, we show what we're trying to achieve and then the objectives we set forth. We carried out this work in two phases. Phase one is completed, phase two is ongoing. For the first phase, we sought to understand in greater details who had the underserved individuals, what are their preferences to access telehealth. And some of the things we found here were, a lot of what I said so far, but also we saw high proliferation of mobile phones. Some have smartphones, some have feature phones, fair to high proliferation of internet infrastructure as well, being Lagos, the economic capital of the country, and very high willingness to use telehealth solutions. So we saw an opportunity there. Still within phase one, we attempted to understand the models that the current existing telehealth service providers were using, what was it that was excluding the target population of interest. And we had interesting findings around their price point, around their channels, that may not necessarily lend itself to the requirements of the target population. So afterwards, we had a design that took us into phase two, whereby we planned iterative learning methodology to make adaptations to existing models and see what improvements we see in terms of using telehealth to expand access. So that's where the pathway methodology came in our need to distinctly identify the target population, understanding that one solution might not fit all, even within the pool of the underserved target population that we're trying to reach. So we attempted to stratify them, and I'll get to what that means shortly. For the first phase that I mentioned, we did geospatial mapping, whereby we checked where are the areas that are populated with actual individuals, shown by activities, socioeconomic activities going on. Where are the health facilities? What are the clinical staffing levels, so that we also had clear evidence of low access. And then we reviewed a lot of secondary data as well, health outcome surveys, NICS, MICS, NDHS, among others, to be able to come to these areas. Ultimately, we identified 64 wards. Next page, please. We identified 64 wards in Lagos. Lagos has about 270 wards, so the spread is really wide, you know. And we sought to further stratify these individuals within the wards. So the problem I already described, one size cannot fit all. This is the framing for our problem statement, right? So what do we need to do for different segments within this population? We recognize that population level interventions can have socially unequal effects, and they may improve overall health but worsen inequities, which is what the telehealth solution or telemedicine solution was tending towards based on our research done. So we use the pathway vulnerability typing tool in our formative household survey. And this uncovered hidden differences in access barriers, health needs, and service preferences. The next slide shows the target user survey, some details into that, and precisely how we segmented and then enrolled into the program. And when I say enrolled into the program, we had signed MOU with 3 telehealth service providers that were willing to tweak their models and willing to provide data for us to study the differences in different approach with different population segments. So we started with a target user survey, whereby we had 6 sections and we deployed to over 1,000 respondents. We collected information such as their locations, their willingness to use telehealth services, the access to technology, the health insurance coverage, whether they or not they have, the healthcare needs that they've accessed in the recent times, and also just a lot on their demographic features. Then we rolled up these questions into an enrollment website to be able to profile and then segment the different target population. We have the specific questions at the bottom of the page, but I think the next page sort of gives a rough sense of what that is. Now, we had access to the pathway segmentation framework, which is a bunch of questions that is administered in a survey setting, like I described earlier. And then that would help you to stratify your population segments. We had to make some tweaks to the pathway questions. And I think it's really regarding the head of household, whether or not it's the household is headed by a man or a woman. And then in relation to the heads of household, we wanted to know if it's self, if it's their partner, to make the question a little bit more robust. And if the gender of the interview is male, an answer to be adjusted, and the answer itself, then we know that it's a male-headed household. The home birth, whether or not the respondent has had home birth, we retain that, and then how many times they've received ANC during the last pregnancy, we retain that as well. So we had sample segments, illustrated at the bottom below. The first one being, the respondent is male, the head of household is the one reporting, the partner is well employed. So we see this vulnerability level 1. We see which is underserved, male-led, M, and then vulnerability level 1. Vulnerability level 3, we see low level of education, we see the religion, we see level of assets they have, and then we see a female-led household on the far right bottom, head of household, female partner, high asset ownership. So these are the sample segmentation that we have for the different male respondents. I'll pause now for King to provide a bit more clarity on the assessment on the field and then the results that we obtained from the segmentation analysis and the subsequent use of the segmentation analysis.
All right. Thank you, Leke. Please confirm, everyone, that you can hear me.
We
Yes,
can hear you.
All right, thanks. Great. So I'll just be sharing some of our results in the next few minutes. Overall, just like Leke mentioned, for the first phase, we conducted a survey and we segmented our respondents across the 3 major vulnerability groups. We saw that 51% of the survey respondents were in the least vulnerable group, 30% in the more vulnerable, and 12% in the most vulnerable. They all had varying levels of education and income and language. So, for example, we could see that the most vulnerable mainly had no education and or primary education. And then the least more vulnerable had mainly secondary education or higher. In terms of income level, we saw that the most vulnerable earned less, 20,000 naira as monthly household income, which is about $13 by today's rates. And of course, the least and more vulnerable earned higher. The most common languages spoken were Yoruba and English. This is not surprising given that Lagos is a majority of the residents there speak Yoruba. So this demographic data confirms that there are socioeconomic disparities across the different vulnerability groups, and we need to design the models to meet their needs. On the next slide, we looked at the level of phone access and internet usage. We saw that majority had phones and internet, but the type of phone and level of access varied by the vulnerability group. So, for example, 51% of the most vulnerable, they had basic phones and smartphones, but the most vulnerable had mainly basic phones. And similarly, for internet access, the most vulnerable had less access to internet at 33%. And the least and more vulnerable had more access to internet. So this just confirms there are technological disparities across the segments, and the models need to be tailored to be able to overcome these disparities. On the next slide, we were asking the respondents from the survey how they would prefer to access telemedicine. We saw that majority preferred to access phones and through voice mode of communication. But interestingly, we could see that the majority of the most vulnerable preferred to access telemedicine care via a community site. This just shows that if you tie this against their level of education and technological barriers, it's not surprising that they prefer to access telemedicine via a community site. So this approach of looking at the needs, the preferences of different members of the population, different segments of the population, helped us design solutions that will be inclusive and accessible to all. So on the next slide, you would see that based on all of these data and findings, we ended up with 3 major models to be able to expand access to care for the underserved population: a toll-free hotline, a market kiosk, and a community pharmacy kiosk. And we built different hypotheses around these, offering free health information at no cost, offering point of care testing, diagnostic services, and all of that. Just to call out that the market is the major piece of work from the survey that we found. And the community pharmacies are it's one of the most accessed points of care for underserved population. So that's why we built a kiosk around that. On the next slide, quickly, I will just share some of our results. Just like Leke mentioned, we deployed these models and to see how different segments of the population interacted with it. From the findings, we recorded over 10,000 uses of these models, and this is data as of June, and this is just over a year. Majority of the users used the market kiosk and the community pharmacy kiosk, so for the hotline. But when we look at the disaggregation of the data by vulnerability group, we could see that majority of the most vulnerable were using the market kiosk. The community pharmacy kiosk didn't serve the most vulnerable so well, but the least vulnerable used it. And in line with our baseline data, the hotline served all levels of the population in the right proportion. So this just showed further that even when you design telehealth solutions, different segments of the population will use it and react to it differently. On the next slide, we tried to show this just further reinforces the point on the last slide in terms of how they used it across different waves. Just like Leke mentioned, we implement this in different waves, wave 1 and 2. So when we started off in wave 1, you could see on the chart to the left, we were not getting majority of the most vulnerable to use the models. And then we came up with different adaptations, right, from KIs, in-depth interviews, exit surveys to understand why this was so, and we made adjustments. So different providers had to adjust their demand generation strategy. There were some adjustments we made to the IVR script of the hotline and even the outreach strategy that we use. So the level of access of the different vulnerability groups informed the kind of adaptations that we made to the model. Just to wrap up, on the next slide, what are some of the lessons we learned? Overall, insights from implementation and utilization of the models across segments validated our hypothesis. The toll-free hotline was widely used across the population, especially for health information. The market kiosk was able to effectively reach the most vulnerable groups and women, reinforcing its role as a trusted primary care entry point. The community pharmacy was able to extend access primarily for the least vulnerable with high utilization of points of care testing and diagnostic services. What are our key takeaways and learnings from pathways? Overall, we can see that the pathway segmentation guided the design of inclusive telemedicine models that reflect user preferences. We could see that what are some of the strengths? Using the pathways framework helped us to helped us to understand the needs, the preferences, and how different segments of the population reacted to this model. So designing was a key strong point in using the pathway models, and we're able to draw specific insights across different segments and tailor adaptations across different segments. So limitations, we were unable to categorize others. So, for example, we had segments of the population, male segment of the population who could not answer ANC-related questions that we had to now use the information of their partner, or respondents who were not the head of household, or their partner is not the head of household. So maybe they are like cousins, grandmother, brothers, and all of that. Lessons learned: incorporating pathway framework into the survey enabled a deeper understanding of health-seeking behavior, technological access, informing preferences for targeted intervention, and analysis of the utilization data helped identify models that are most effective in reaching different groups of the population. So overall, it has been an interesting years of study, especially using pathways. I think that should be all from our end.
Yeah.
Yeah, I think that's all.
Just to mention before we hand it back to Amanda, this work was done between Solina in collaboration with Village Reach. We also had the Pathway, the Sonda team that was with us through the process of adapting the pathway segmentation methodology, and also carried out some of the validation of the segmentation with us. I think by and large, the most important thing that we sought from the segmentation is that between groups, there's a lot of similarities, and across groups, there's a lot of differences. And I think we're able to see that from how people reacted to different models and how we're adapting. This conversation is not covering a lot of what adaptations were done, because we're trying to keep it targeted, but we had to make tweaks along language, along the channels, along demand generation method, all based on our understanding of the profiles of the different segments we had within the underserved population. Thank you very much for the opportunity. We'll pause now we hand it back to you.
Great. Thank you so much, Leke and King. Excellent presentation, really thoughtful and kind of going into how you use the different pathways tools and some of your results. So really, really great. I would like to ask everyone, this is our community webinar. So if you're able and have bandwidth to put your cameras on, it's a great opportunity for us to see everyone. And if you have questions about the presentation, please drop them in the chat or raise your hand and I can call on you. While you're all getting your questions together, maybe I could ask just a broader question, Leke and King. How scalable do you think this segmentation informed telehealth approach is beyond Lagos?
Yeah, thank you very much. We believe it's very scalable, and there's a lot of use case for it beyond Lagos. Lagos is a very good place to test because it's technologically advanced and just has a clear digitization roadmap. But other states are catching up to this as well. The segmentation methodology in of itself, it applies, right? Because I think the pathway segmentation methodology lends itself to rural, underserved communities, and we have a lot more of those communities even outside Lagos. So yeah, it certainly does apply. We think the model can be a bit more flexible and robust against some of the challenges that King mentioned earlier, to just anticipate different kind of respondents that may not be able to answer to some questions that are required for the segmentation analysis. But otherwise, I think it's incredible and should form a clear basis for the initial assessments that every state would need to do in stratifying their population and then tailoring telemedicine solution and even any other solution, frankly speaking.
Thank you. I've got another question, but I'm going to pause and see if anyone from our group here has a question. Please don't be shy. I'm not seeing any hands or anything in the chat. Maybe I'll go to one of my other questions. So you mentioned phase 1 is done and you're in phase 2 right now. Do you have any early signals or examples of impact from the models, particularly from the most vulnerable? I mean, you talked a little bit about the use there, but and those statistics, but is there anything else you can share in terms of what the impact is based on how you've adapted the telehealth models?
Yeah, I mean, I can start and King can add to some of the impact. I think the biggest impact for us is in identifying in a very seamless way the population segments that wouldn't have had access to healthcare at all. So we've seen the utilization rates that King presented. Some of the exit survey we did, we had 20% of the users mentioning that they wouldn't have used healthcare services at all if not for the telemedicine option that was provided to them. For health education, that is. For uh, teleconsultation, we see a similar pattern as well of individuals that wouldn't have used telehealth services at all. So we're very excited that our solution is indeed targeted, the adaptation is indeed targeted. I mean, there's some population segment that would mention, okay, yeah, if we don't have access here, maybe we'd have used the pharmacy and all that, but we're very proud of the 20% and the 40% that we're able to filter out from the segmentation. I think the other thing worth noting is the referral that we're able to achieve, from the population that used the healthcare system. So not only were they brought into the telemedicine space, some were referred outside to PHCs, and that was like their entry points into the formal healthcare system. So we think that was incredible as well. Some referred to laboratories to run scans, to specialists as well. Individuals that haven't run any test of any chronic diseases before that were able to do so because we're able to systematically seek them out. Yeah, maybe I'll pause for King to add to some of that as well, maybe some points.
Yeah, thank you, Leke. I think in addition to everything you've said, a major impact we've seen is increasing preventive care seeking. During the initial survey, a lot of the members of the population would typically seek care when they are sick. When the situation is getting bad or almost bad. But over the course of implementation, we could see a huge uptick in the number of people seeking care for chronic disease management. So a lot of people will walk up to the kiosk. I think over 20% of use cases are for chronic disease management to say, I want to check my BP, I want to check my blood sugar level, and all of that. So a huge uptake in increase in preventive care is one impact that we could see over the course of implementation.
Yeah, and maybe to say a little bit to that. Thanks a lot for bringing out King. So we're expecting that the least vulnerable will spend the most on healthcare, and conversely, the most vulnerable will spend the least on healthcare. And we found a very conflicting pattern of the most vulnerable that have the least income spending more on healthcare, right? And that's because of what King said. They mostly seek curative services. Wait till things have gone really bad. So we saw a very big opportunity to turn that narrative around by encouraging them to seek preventive care that King mentioned, and also other measures like state health insurance services and other things. But by segmenting, we're able to see that pattern, and it was quite interesting to observe. Over.
Excellent. Great. I really like that note about the preventative care. That's so important. And getting in early means less need for, intensive care services later, less stress on the health workforce and in the health system. So that's great. Jamila, just noting your comment in chat. Welcome. We're happy you're here. Excited that you've been part of this process. So thank you. One more call for questions. Okay. All right. There might be some additional questions that folks have and may reach out. So King and Leke, Be prepared. And just want to again thank you both for your excellent presentation today. As a reminder, we'll be posting the presentation and the slides and everything on our community resources page. So stay tuned for that as we, next week probably it'll be shared out live. Okay, handing it over to Lee to take us through our Pathways Survey presentation along with our colleague Lang. Over to you, Lee.
Hello, everybody. Today we're going to be talking about work that we've done over the last few months to update the Pathways Survey. Next slide. So the Pathways Survey, one important question is, what is the Pathways Survey? Now, this is a quantitative household survey. It targets women of reproductive age and their households. It's available as a global good, so that means it's free for anyone to use, both the survey tools and also the results. And this survey contains the information that's listed on the right hand of this slide, including health behaviors and outcomes, including items like child nutrition and mortality, behaviors like home birth or facility birth, breastfeeding, family planning use, and childhood vaccination. Importantly, and this is an important differentiator, it includes a lot of information about social determinants of health. And this includes social support and support available in the community, household economics and living conditions, human and natural systems, such as infrastructure that affects people's ability to lead healthy lives, health mental models, the woman and her past experiences, as well as relationships within the household. Next slide. So I said before that the Pathways Survey is unique, but what exactly makes it unique? And I'm a big fan of this survey, and I think everyone should know that I think this survey facilitates the research on essentially exposures throughout the life course of women that are social, cultural, economic, as well as their current health status and behaviors, and the health status of their children as well. And so this survey was designed based on the Pathways Vulnerability Framework. So really, almost all of the factors that we're interested in are included in this survey. And it captures, as I said, all of these social, cultural, behavioral, economic, and other factors that are really not collected in most other surveys or are collected superficially in surveys like MICS and DHS. This is really woman-centric and gender intentional. It started with qualitative research, working with women about what mattered to them in their lives. We've also worked with gender experts in this revision to strengthen the way that we ask questions and make sure that we fully understand women's lives holistically. It can support life course research. And so questions, like whether or not women went hungry during childhood and how that relates to, or if they dropped out of school, and how that relates to their current health status and behaviors. It was designed for use with Pathways segmentation methods. And because of the methods that we use, sometimes we lose a lot of observations in other surveys like DHS. This is designed so that we can actually take advantage of the full sample. And there's a women's questionnaire and a men's questionnaire, and this allows comparison between women and their male partners when it comes to their beliefs, behaviors, knowledge, etc. And it really provides this holistic view of women's lives that is absent from a lot of other surveys, and it can be used potentially for a whole variety of analyses beyond health. And it really sees women not just from their reproductive lives, but women as whole individuals in every aspect. Next slide. And so how has this survey been used in the past? So the first version of this survey was really introduced in 2021, and data was collected in Kenya, in northern Nigeria, as well as rural parts of Bihar, India, in 2021 and 2022. And these results have been used for segmentations, which are available to our entire community. And I should also say that even the first version was head and shoulders above a lot of other surveys in measuring social determinants of health. And so we really welcome people who are interested in conducting research using these data sets. They are available. And so we encourage you to reach out and speak with us about accessing this data because it's very rich, including the segmentation, but even beyond. I'll pass over to my colleague Lang.
Thanks, Lee. So really the needs of revising the survey actually came from the user experience. So as we develop the segments and work with our partners in Kenya, Nigeria, India, and also as we extended our segmentation work to new geographies like using DHS data, we started to notice some very important gaps in our first version or like previous version of survey. So we revised the survey to address those gaps. So now if we compare the current new survey with the previous version, the first thing you may notice is that the new survey now better captures some important or critical areas like child immunization, gender norms, women's time poverty, her health mental models, and also the social support she can have. And where possible, we have also replaced or supplemented the old question items with validated measures that are already used in a similar context. So for example, like questions on women's decision-making, her economic empowerment, and household food security, those questions now are aligned with other global instruments. And by aligning with other standard validated instruments, the new survey now will allow us to have a stronger comparison across country. And in the end, of course, we have also removed a couple of questions for which data was never or barely used. And we also streamlined the questions to improve the data cleaning efficiency. I will give a quick example here, like what Lee was mentioning about male questionnaire. So earlier we have just one simple question that includes, we try to capture data from women at reproductive age, from the mother-in-law and from the head of household, and also from her partner. So everything is actually in one survey, and it makes the whole data structure very complicated. It's a nightmare. I shouldn't say nightmare, but it's very difficult for data scientists to clean the data and also to find the most useful data points. So now, like with the new survey, for example, for the male questionnaire, we are not repeating like all the same questions you ask for the women. We only focus on particular areas where we think we should actually try to understand more about the difference between women and her partner. So like particular questions are asked for the male partner. So how do we go about this process of revising the survey, and where are we now? I would say this is a very collaborative process. So it starts from collecting feedback from stakeholders and synthesizing all those input, and then followed by a very dedicated in-person co-creation workshop in Addis Ababa with our partner Project Hope in Ethiopia. And throughout the whole process, we try to focus on like 4 guiding principles. First is relevance. So we, of course, we want to make sure the questions we ask are directly supporting the core objectives of the survey, right? And also minimize the redundancy. And then validity and practicality. This is really to balance between using validated measures and practical context like ethical considerations or cultural sensitivity. And in the end, we also need to minimize the systematic unace in the data. And this is to really serve the purpose of properly running a segmentation. So we carefully review the skipping patterns in the survey to make sure we don't have unnecessary non-responses in the final data. And Ethiopia being the first country to adopt this revised survey tool, they have customized the instrument and also complete the field testing. Now we are in the final phase of incorporating those feedback from the pilot to finalize the data. So approximately by the end of August, when you go to the Pathways public knowledge base, you will expect to see the updated survey up there. Next slide, which you will find includes like 3 questionnaires, 1 questionnaire for women at her reproductive age, and 1 questionnaire for the household she lives in, and another one for her male partner if she has any. But you don't have to worry about, missing out on the release of the updated survey, because we will send out the newsletters and also announce it on our social media when it's ready. And together with those questionnaires, you will also find a very comprehensive handbook, including several documents like a manual for interviewer, a sampling strategy memo, and also a template for properly assigning the weights for the survey. All those documents in the handbook are designed to support different teams or countries implement the survey effectively and also consistently across different diverse contexts. For those of you who participated in our previous webinar, or I know some of our partners here have been using the typing tool, right? I'm just gonna briefly say that the update of the survey questions doesn't change anything about how those tools or products are generated or how they can be used. But you will probably see some new contents like indicators or questions being used in the typing tool. Let me hand it back to Amanda.
Great. Thank you so much, Lee and Lang. Really appreciate that nice presentation and overview of the updated Pathways survey, and really looking forward to seeing that shared live at the end of next month. As they mentioned, we'll let everyone know when the survey and the handbook are ready to be accessed, and you all can use it. So at this point, invite you all to cut your cameras back on and ask any questions that you have about the presentation on the updated Pathways survey. We've got
Amanda,
one.
I can voice over my question if no one else has one. Sure. Okay. So hi, Lee. Hi, Lang. Thanks for the great presentation, and lovely to see these updates. My question is around sort of best practices and boundaries related to survey deployment. So going forward, maybe as the Ethiopia work is finalized or the field testing is finalized, how are they thinking about the deployment, both size, array, in relation to sort of the explanatory power of the updated survey? I'd be curious how others can think about the size of the deployments in other countries in relation to the Pathways instrument or any other surveys they've been sort of part of in the past. Over.
I'm happy to talk, or Lang, do you want to go? Sure. I'll just say that I think a lot of the best practices and boundaries are what's provided in the handbook and materials that accompany it. And so in Ethiopia, it will be a nationally representative survey. And so there are guidance for sampling to ensure that it is representative and that we can rely on the results. And I think that, what else was I going to say? No, I think there's clear guidance in there for its use. And generally in the past, Pathways survey has been representative at national level and not at smaller geographical levels. But once again, it could be adapted for a variety of uses, and there is guidance within the document for how to do some of that.
Thanks, Andrew. Thanks, Lee. Lee and Lang, oh, Jamilu, I see you coming off of mute. Do you have a question?
Not really a question, just to like kind of commend the team, because like he just said, there's a possibility of using the same pathways in other aspects of development, not necessarily just only health. So I just like kind of look forward to having the tools coming up live and available at the end of August, and let's see how we can use the tool to like test the vulnerability of other aspects of the development sector, not just for the health sector. Thank you.
Thank you.
Amanda, there was a question in the chat placed by Kelly on the previous presentation. Do you want to go back to that potentially?
Sure, we could do that. And if you have any other questions about the survey, please drop them in the chat. We can go back and forth between presentations with our few minutes here. So Kelly, are you still on the line? Do you want to voice over your question?
Sure. Yeah, thank you for going back. No, I was just very interested in what the team said about the insight of how when they looked at the segment data, their initial thought was, oh, the least vulnerable or the most vulnerable will spend the least amount of healthcare, and that wasn't the case. So I was just wondering, was there anything that really surprised the team when they're using the segment data that then influenced maybe making like a different decision for the project than if you didn't have that segment specific data? Like anything that, in addition to that cost insight, is there anything else that really surprised people?
Okay, maybe I can jump right in. I think on that, maybe one thing that surprised us would be the utilization data for the most vulnerable for the hotline. So from the initial phase, majority preferred the community site, but a significant number preferred the hotline. But when it comes to use, the utilization for the hotline for the most vulnerable was a little bit less. I think that was a little bit surprising. The segmentation data was able to bring out all of those differences, right? And that helped us to then dive deeper to see why is this so? We probed using IDIs, exit surveys, and one user, for example, which is from the most vulnerable segment, the feedback was, oh, when I call the hotline, there is a machine that answers me and I feel like it's mocking me, right? So that helped us to go back to see, maybe they are not using it because their education level is not so great. The IVR is a bit confusing for them. So they had to then make adjustments into how the IVR was designed. So that was one thing that was very surprising in terms of utilization of the hotline from the most vulnerable, because our assumption was it's a voice. You have a basic phone, you just pick up your phone and call. But the fact that the way you design the IVR affects how different segments of the population would react to it, that was a great insight to see, and that led us to make some assumptions, some adjustments, which then led to a slight increase in uptake from the most vulnerable group as we move through the course of implementation. Over.
Thanks so much. That was that's also like fascinating. So yeah, using it and testing it was really helpful. Thanks so much.
Thanks, Kelly. I see some discussion in the chat from Mary about the tools. She asked if the tools allow for segmentation data updates to adapt to changes in socioeconomic status and other evolving factors. Lee, do you just want to voice over your response quickly?
Sure. I think just like other cross-sectional surveys, we expect that these results are valid for a period of time based on how fast things are changing in society. And so we have quite a high degree of confidence in these results, at least for a series, a number of years in most instances. And I think we can talk about this further in other unique circumstances. Yeah.
Thank you. Thanks all. We've got one more question. Was the IVR, this is going back to King, and like was the IVR adapted into the local language, or was it deployed in English, or both?
Maybe I can also quickly answer. It was deployed across multiple languages, English, Yoruba, Hausa, Igbo, and Pidgin, right? The challenge that we observed, Jamilu, was that the most vulnerable complaint of was the way the message was framed and the length, right? So from interaction, we could see that immediately they call, they would prefer to just, okay, I have this problem, can I talk to a doctor? So we then shorten the length of the interactive voice response such that they're able to quickly select their language preference and then immediately connect to a doctor. That was one adjustment that we made. Yeah, over.
Thank you. Thanks. Love these questions. We've got a few more things to get through before we close. But again, a big thank you to Lee and Lang and also to King and Leke for your excellent presentations today, taking all of these questions. I know that's sometimes the hardest part of a webinar, so really appreciate this. All right, we're getting our last bit of slides back up. So I just want to share an exciting update with you all. I've mentioned before that Pathways will be at World Health Summit. So I want to share a little bit more information. Our presentation on improving maternal and child health through data-driven segmentation, making the social determinants of health actionable for women and children, is going to take place on Monday, October 13th from 9 to 10:30 Central Europe time. There's a link at the bottom. Maybe one of my colleagues can drop that into the chat. But this is a part of World Health Summit on the main agenda, which means it will also be live streamed through the World Health Summit YouTube channel. And it's free to access that. So information coming your way on how to engage and register for World Health Summit. And throughout this 90-minute presentation, we're going to be packing a lot in. We'll have some interactive presentations. We'll have some exciting new videos highlighting our work. We're very excited about a panel discussion featuring Pathways champions and users from Nigeria, Senegal, and Ethiopia. And then we'll also be launching some very exciting things and having some exciting Pathways announcements. So if you're planning to be at World Health Summit, please don't hesitate to reach out to me. And also we'll be having events at the International Conference for Family Planning. More about that soon, but if you plan to be there, please also reach out to us and let us know. Next slide. How can you stay engaged with us? Please continue, engaging. You can sign up to receive our notifications and newsletters if you haven't already. We have our community website. I'll drop the link in just a moment, where recordings from these webinars are shared. We have these in-person events that I mentioned. If you're going to be there, let us know, because we hope to see you, and we want to make opportunities to see you. Lastly, we'd really like to have your feedback on this survey. I've put the link for that in the chat, and the barcode is here for you to scan. Just feedback on this webinar today. It's a 4-question survey. It really helps us in tailoring all of the different things that we are providing to the community, the types of conversations that we curate, and how we do this facilitation. And then I'm also dropping in the link for the Pathways community site. So this is where you can access the recording from our last webinar, as well as some other materials.
And there was a question that was added to the chat about other interventions that the approach has been tested with other than telemedicine. So Amanda, do the resources on the Pathways site, will that help address that question?
I don't think so. Rebecca, were you talking about the survey tool?
Yes, and I'm new. I'm just here to learn. I haven't been part of the work, so I might be missing some context. But yeah, this was just such an interesting application of how interventions can be adapted based on socioeconomic status. And I'm just curious if there have been other interventions tested that I can see and take a look at, just to see how we can maybe adapt for D-Tree.
Yeah, we do have other case studies that are available on our website, so maybe we can.
Rebecca, I'll follow up with you. I should have your webinar from your registration. Yeah, Lee, go ahead.
I'll just briefly summarize that family planning, maternal nutrition, and primary health care have been 3 leading areas. We're also starting work in adolescent health and more holistically looking at the needs of vulnerable populations. But we'll talk more.
Great. And happy to have you here to learn and listen. Great. We're at the top of the hour. Thank you all so very much. Thank you to our presenters. This has been an excellent webinar. And we look forward to seeing you virtually and hopefully in person at some of our events. So thank you all.